Shefali and I'm the marketing consultant for Ravens Recruitment. With the recent upscheduling of coding products in Australia, I decided I wanted to educate myself, students, means for our patients and their health. I also wanted to learn more about how to manage pain and changes with respect to coding. So I have with me today Joyce McSwan. So Joyce graduated from Monash University in 1996 and is now a multi-award winning clinical pharmacist, educator, and program developer. With 18 years of experience in hospital and community pharmacy, therapeutic education and aged care, Joyce's true passion lies in helping others gain better access to pain and medication education for consumers and all health professionals. She is skilled at transforming evidence practice, helping others to do so. I heard Joyce speak at the Pharmacy Guild of Australia's Pharmacy Connect conference last year and knew I had to collaborate with her at some point. So thank you for joining me today, Joyce.
That's all right, pleasure.
You became interested in pain, and what has your career journey been so far?
Yes, it's been rather very odd career journey. I didn't think I'd be where I am in where I'm sitting, in terms of having innovated so many programs within the pain space. I started out as a community pharmacist. I was always quite a restless pharmacist, always wanting to, do something different to keep my day going as such, So when I was a community pharmacist, even just as a pharmacist, in charge, not so much even a manager at the time, I would run, clubs for the pharmacy assistants, and I would always be making something up. And that just kept me, I think, interested within my work. So as I progressed from there, I became essentially an accredited consultant pharmacist and found it very interesting working in aged care. So for a very long time, almost 8-9 years, I was in aged care consulting with the local nursing homes or aged care facilities and the GPs. So that gained a lot of clinical confidence over time. And really it was probably in the around the summer of 2010 when, probably more around, 2008, when questions kept coming up from aged care facilities about pain for the elderly. And I kept finding myself repeating myself, paracetamol regularly, or, what do we do with Norseman patches? And I think it was because the aged care facilities at the time were going through accreditation. So they had to have, good pain management strategies, and everything had to be standardized. So I was called in to help them in all the hundreds of beds that I was looking after at the time. I think it occurred to me there that, if someone keeps repeating the question to one aged care facility, surely the whole lot of them have this question, right? So I started to put together, I was already teaching in aged care facilities because they needed CPD points. So my first ever work in pain was putting together a 4-part DVD where it was me just teaching the content of all the questions I kept answering. And at the time, I sort of launched it into all aged care facilities in Australia, which was quite a big job on my own. It was literally faxing all the aged care facilities about this package. Do you want to learn more about pain? And I just literally faxed to every facility. Thankfully, at the time, the Royal College of Nursing approved the program, so they accredited it. So that meant that they got points. And it was from that experience that was my first time of going, oh, I think I like this area. I might have experience with research. Yeah. So it's always been about meeting a need for me. It's always been about identifying a need and looking at what's there. And I think when there isn't anything there, I've often gone, well, let's just do it. So I suppose that was the starts of it. And since then, there's been more pain program developments in so many other fields, whether it's for the Commonwealth, primary health networks, whether it's for pharmacy, which is my PainWise pharmacy program, and we'll talk about a bit more about that later if you want to. So yeah, that was what started. So now I find myself supporting pharmacists from with all the experience I have. I just want to help them to learn the things I've been able to learn. And I get that not every pharmacist can have the opportunities or time to do the things I've been able to do. So I simply want to give them the knowledge that I now so that's how it all began.
That's so great. I mean, you've obviously recognised that there is a need for more education, and as pharmacists, we are learning every day. So the fact that you get to teach us from your experiences, I think, is really valuable.
Yeah.
That's excellent. And so obviously, we know from February this year, all codeine containing products became prescription only. What are your thoughts on that upschedule?
Well, look, I think it was inevitable. I think it was coming. The statistics highlighting where opioids as such, not just codeine, where opioids were going, and the trends of that was sort of started in 2000. And in a way, part of my work was also watching that. By 2010, I had realised, hang on, here's the rise, because they picked up the issue between 2000 to 2009. There was some really significant rise in opioid prescribing and PBS usage of it. And that's for so many reasons that contribute to that. It's not a finger point at anyone, really, merely that we've got a significant problem happening. So that was just totally on opioids, not just codeine. So, that was in 2000, 2009, and now we're in 2018. So we've had a lot of grace, I think, in time, and those who've been in practice for a while would have seen the codeine changes happening, the pack size, the moving from S2 to S3, it hasn't been an overnight take it out from under the carpet. It's been quite progressive, and we've had almost 9 years of that movement as well. And obviously towards the more 2014, 15, 16, more and more evaluations were done specifically on codeine, so that then we had more data on really what was the problem with codeine itself. And it highlighted, without a doubt, that there were significant issues. So therefore, the public usage was not in the way of what it was indicated for use. There's a bit of a mismatch there. So therefore, we need to action some safety measures around that. And essentially, that's what's happened. So I think from a safety point of view, sure, I think it was, it is necessary, because we are driven by how the usage happens. Even pharmacists doing their role to their utmost cannot always safeguard the usage. As such, patients can go to different pharmacies. There's so many variables, and that's probably what's also contributed to the problem now. So certainly the science pointing to what we had over the counter in terms of codeine, we do know that anything under 15 milligrams is really not going to, cut the mustard in managing acute pain well. And in fact, even though it is convenient, and some people who will benefit from that small dose because they metabolize it, well, or whatever the case might be, still, by and large, it meant that if your dosing wasn't managed well with the right dosing, you simply are going to repeat dose. So that's going to be problematic in the long term, because you're going to be taking more and more because it's not lasting it. So now that we know what effective dose of codeine is required to manage true acute pain well, it is now the dose that is more the prescribed dose, between 15 to 30 to 60 milligrams in some cases. We can then go to, if required, and get that effective dose. So I think in fact, this morning, literally just before your call, I had a doctor call and say, look, my patient has come and said she can't access codeine anymore. And she's admitted to the fact that she is dependent on it. And it started because her husband actually committed suicide. And she went on this, it was just for something sort of low scale, like lower back pain. Wasn't that severe, but she took it as a coping mechanism for herself. And she, because it's now not available, she had to come to have that conversation. And she said, you know what, I'm glad it's happened because I'm done. I need to do this well. I need to address all the issues to get me here in the first place. So it's very interesting what it's, and the doctor was ringing saying, can you help? So it was very much a collaborative effort, which is wonderful, which is what I think this is allowing for.
I think, in terms of implications for those patients who are codeine dependent, using example, it's actually encouraging them to have that conversation with their doctor. And it's encouraging that interprofessional collaboration. So, a good thing in that regard.
I think we'll have a period of, just that little bit of middle of the muddle type of clear up. It will absolutely sort itself out. No problems about that. I've worked in countries where it simply doesn't exist and people are still managing their pain there in other ways. So I suppose I get it that it was a change and it is a big change. And yes, there are some inconvenience factors. I get that. Definitely, for particularly the ones who were using it quite legitimately, I think they feel maybe a little bit invalidated by that, However, I do think that it is opening, on the good side, it is opening more conversations up. And by and large, I think acute pain has a very high inflammatory component. And not that I'm saying that the management are anti-inflammatories. In fact, it's not always. So many things contributes to inflammation, from our diet to our stress levels. So it may mean that we start to talk about those more non-pharmaco related management. But having said that, by and large, acute pain has a huge inflammatory component to it because our immune system kicks in. And I suppose if we were just managing it with codeine alone to mask that, we're also missing that pathway of, okay, how do we reduce this inflammatory process? And like I said, it's not always about a pharmacotherapy that reduces inflammation. Looking at all the influences of inflammation, even in an acute setting, is really important. So I think that helps us to, get the biology right, the pathology right a bit more.
Definitely sounds like you're aware that there are non-drug options that are equally important. What is the sort of evidence around maybe the efficacy of those and other over-the-counter analgesics compared to codeine?
So there are really good options available now. I think what's important, as I said before, is to look around the influence of inflammation. Because as pharmacists, of course, we're wired to think, drug, inflammation, click that together and there's your solution, right? It's not, and I think I want to be very clear on that in fact, first we've got to make sure that we understand that there are many different influences around an inflammatory response. There's stress, there's dehydration, there's muscular tension, there's, there's certainly the prostaglandin process in itself. And substance P as well, so there's so many other modulators around that. So I think number one, we've got to get our heads clear on that, because when we're clear on that, then we can attach the options to it. So from a non-drug option, let's start there. From a non-drug option, certainly there is, better stress management. There's relaxation therapies. They're all evidence to reduce cortisol. And cortisol is a hormone that is a very big driver of inflammation, definitely. So we've got, we've got hydration. That's really important. We've certainly got, if some people need it for psychological management, cognitive behavioral therapy, mindfulness therapy. So from even, depending if it's appropriate, yoga, so exercises, gentle exercises can very well reduce inflammation, even in an acute setting. Reduce the exercise, but still having exercise is still really important, because usually in acute pain, people go, oh, I'll just stop and do nothing. And if you stop and do nothing, you're going to seize up, yes, it's going to compound the healing or delay the healing problem length of time. So I think, first of all, unpacking that is really important. Then you've got things like nutraceuticals or supplements. Depending on the condition, we do have curcumin. Curcuminoids are now very evidence-based for osteoarthritis, for example. But there is some role for it in some acute, lower back pain states as well. So we've got those things that are there. There is some evidence around, magnesium. It is a little bit on the weaker side, but, there is certainly some applications there. Topicals are largely underused when it comes to an inflammatory response. So not only is it all about oral, but topical non-steroidals, even topical capsaicin, and I think synergizing those things are really helpful, because they work on different mechanisms. So when you synergize a capsaicin mechanism with a non-steroidal mechanism, you essentially target two different gates of management, which works really, really well. So we're not even at the tablet stage yet, and there's already so much that can be done. Can you see that? So the patient starts to go, oh, wow, okay, what hope? Or, I can try these things. Then there's also heat therapy, thermotherapy, that can help to initially distract the pain. We don't want to keep distracting the pain all the time, because then we're, not addressing it. But initially the distraction doesn't hurt. To just get the brain sort of shifting away from that pain sensation. It's easy to trick it. Or cold therapy, whatever suits the condition. Or TENS. There's good evidence around TENS therapy as well. The electrodes type of pads that you put on, even just really low current, just gives a different stimulation for the brain to sort of go to, influences our gate theory in pain. And then we get to the drugs. And I very purposely did it that way, because as pharmacists, we go the other way.
And a lot of our patients are not, keen to go straight for the drugs, but we don't even let them know that there are other things that they can
I know. And can you see how, by explaining at first the influence of inflammation, it makes it so much more meaningful as to, or makes it much more sense why I would have said relaxation and stress, rather than, oh, you've got acute, lower back pain. Hey, you should try and, do some relaxation therapy. I mean, what's the relevance in that? But if you actually explain beforehand that, well, part of the inflammation influencer or contributor or process is your, cortisol rising and the stress response, well, let's look at those options and then move towards the drug option. And certainly in the drug option, by and large, what we're left with now is a fair bit of a non-steroidal mix, all right? Whether it's non-steroidal with paracetamol, which has got excellent study results, the Daniel study that shows that, 2 ibuprofen codeines are equivalent to one paracetamol ibuprofen. You know, we've had those studies that are really clear on the efficacy at that level, which calls to question, well, you know, how powerful was codeine in the first place if studies like that are showing that there's some sort of head-to-head comparison, you know, which is why we have products now like Neuromol and Combigesic and a few of Mucinifens, you know, a few of those that dosed at just one 3 times a day, because the one was shown to have equivalence to equivalence in potency to the ibuprofen and codeines. Having said that, those studies were done on acute dental pain, which was a severe variety of pain, and it is. So obviously you have to, as a pharmacist, you have to translate that to, you know, here's the side of shoulder. Can I translate that science confidently? I think you can within that short period of time. But clinical trials are not, you know, done on acute dental pain. Is an acknowledged form of a pain stimulus that is, you know, that is an acute pain stimulus. So I suppose, you know, there are those combinations. But not forgetting, if we didn't want to go the combination products, we do have got your plain Jane non-steroidals, you know, your naproxen, your diclofenacs. Certainly, I think as pharmacists, what we need to be very clear on is how we understand the potency. So we know where the ibuprofen potency is compared to the diclofenac potency. So I think that's important, because we can sell that over the counter now, and we now have to be quite comfortable with the diclofenac trials, for example, you know, understanding what they've been head-to-head studied with. One thing I found out recently while I was preparing for a talk, which was wonderful because you never stop learning, is that, you know, 2 diclofenacs 25, which is 50 milligrams of diclofenac, had better and slightly longer effect than 100 milligrams of sumatriptan.
Oh, okay.
Which is fantastic, because triptans for migraines, this is for migraine, you know, can cause rebound headaches, because if we use it too often, we get the rebound issues. So I suppose, you know, we have that option if we were aware of that clinical trial. I mean, I ideally want to, and I just haven't had enough time in my day, ideally want to do a training on really understanding non-steroidals, because I think there's a lot of myth out there about non-steroidals, and I think some of that is, and if that's what we have now left over the counter, we've got to be able to handle that well. Yes, that's right. Yeah. So I suppose in a nutshell, you know, there's the non-pharmaco stuff I mentioned. There's the nutraceutical stuff, which has a role. And there's certainly the drugs, the pharmaco stuff that is there, that is weighing up reasonably well in terms of the short-term benefit and engagement of use. Beyond that, as a pharmacist, now with Pain Meds Check coming on board, which is amazing, we then can have the longer chronic conversations with patients on that level there. I mean, not to say we can't talk about their acute pain there as well, if they're spiking lots of acute pain, but it gives us that platform to have not just that over-the-counter engagement, but to have that little bit more. And I think that's great. That's a total package for us, you know, if we took up on it, you know, or if we got skilled on it, I think is what's really missing and really important.
Okay, great. Now, something that I'm aware of is that your particular sort of skills and talent comes from adapting therapeutics to the individual. You look at the whole person-based approach, and you're good at collaborating. And one of the ways you've done that is through your pain programs.
Yes.
in particular, the one that I've heard of is PainWise clinics.
Mm-hmm.
Who's out there?
Yes, PainWise was designed out of all my experience. Just going back a little bit, I explained about how I, got into the medical teaching field. And then I actually got very curious in pain from a level of all this multidisciplinary approach, because that's what the evidence kept saying. And I did a pilot by myself and a small team of allied health professionals in regional Queensland. And we brought together essentially a pain education program for patients and a support network. That went gangbusters because the region had so little, and it went really well. And it just gave me some early insights on, what does pain programs look like? So from those very unelegant early days, I then designed pain programs for the Commonwealth. And at the time, I moved to the Gold Coast, and very fortunately, the Primary Health Network was looking for some solutions. So I presented my model, which was, how do we reduce wait list? How do we help patients to get into pain education earlier? So they were happy with that idea, and they were happy to trial it. So that was a very quick learning curve, going from my very unelegant, regional country type of pain program setting to having to make it real schmick. Yes, so that was it was the team that was necessary. It was collaboration from peers that pulled it through, and that's why collaboration is so important. And it takes time to collaborate. It takes a lot of cups of coffees. Because you always need over coffee, or you entice them with the coffee. I'm not sure which one it is. You gotta pull your carrot sticks. Anyway, PainWise was designed out of all my experience in the Commonwealth type of pain programs, and my profession, you guys, came back and sort of said, well, Joyce, you've done these sort of pain pathways and pain programs for the greater, community. Is there anything out of that pharmacists can do? And I sort of went, oh, good question, Sure there is. It's such a big elephant to eat. I mean, we're talking about a 24 million population, and 1 in 5 of those suffer pain. That's still a lot of people to look after. So there's no competition here.
Yes.
So out of that, I looked at the programs I had on the Commonwealth, and I went, okay, if the patient finished with a program like that, and if they were to go to a pharmacy, what would I like them to have? And what can the pharmacist continue on the work with, so that, all the good work that's been done there keeps going? So essentially, PainWise Pharmacy Professional Service Program, it's the only one in the world, actually, that is for pharmacists to use, specifically for pharmacists to use. Provides the pharmacist to be skilled in all the lingo that is going on in the pain world of the pain programs, bringing it into the house of the pharmacy for the pharmacist to, of course, do their scope of practice, which is all the medication stuff. But, and sometimes it's de-prescribing, it's not always prescribing or recommendations. And then to help the patient to get more self-management as well from that. So the whole program starts at foundational level, which is just very easy entry point stuff, over-the-counter engagement stuff, big on communication in pain, because it does matter to get the results you want for the patients. And then it goes on to our advanced program, which means that you get a lot more case study based niche areas of conditions to manage, and all the therapeutic support that goes on with those conditions, from a drug perspective, from a nutraceutical perspective, from a non-pharmaco perspective. And then our plus version, which looks at actually pharmacists being able to host a 4-week topic-based self-management program to the similar level of the hospital type of programs. Yeah, so not everybody needs to go all the way. Some people want to be just down, the foundations and at the moment. So, yeah, so the ones on the map, which we have, which is quite visible, are the ones that are trained in PainWise so that patients can go and find them. Because half the time you hear a pharmacist doing really good work and you're like, how come I didn't hear about you before? Like, I didn't know you were great for wounds. Like, how do we find that? So what PainWise has done to help my peers and my patients is to go, all right, if you're trained in this and we're speaking all the same language, let's put you all on a map so that the patient needing help can go there, or I can inter-refer. I've got my patient, and it's happened many times. Yeah, so that's how it all came about, and that's what it's about.
Great.
It's important for both
and pharmacists to know exactly who to turn to, so the patient is given the right information. And just, I don't know enough about this, I know that there's someone out there who does.
Yeah, because health navigation is really hard for a patient, and they're all vulnerable. So they'll do anything, see anyone. That's right. And that's hard. So I want to make sure that they're navigated to people who've been trained, who's going to keep that consistent information. So I can assure you that no PainWise trained pharmacist will tell the patients that, the pain's all in your head. No way. That's because the training has been such that we know how to explain how pain comes about in the body. So it's then meaningful for the patient. So I think at least at a very basic level, we're all speaking a consistent science. And that's important. See, in the physio world, that's definitely the case because of some really key people who I observed were driving that, but it wasn't happening in the pharmacy world. And so I'm like, well, that's going to be not helpful for the physio who's been telling the patients all about this updated science. And then when they come over to the pharmacy world, what do we tell them?
Yeah.
That's right. So I think my sort of burden, I suppose, was to try to, having seen what I'd seen, it was as if the treasure was there. It was like, I know this stuff, and oh my goodness, what a
way to the treasure.
Yeah, that's right. And I just went, if I could just put the treasure on a platter and give it to pharmacists and they don't got to go find the treasure. So essentially, the collateral material that we've made up, the forms and all that, where they can put their rubber stamps on, makes it look like there wasn't me, that PainWise was their own invention for their community, because who am I? The patient doesn't know me. They know the pharmacist. So the design of the program was so it looked like whoever was PainWise, devised it on their own so that they could own it and bring it to the community as their own, because that's who the community trusts. They don't trust me. They don't know me, and I can never reach them. But they trust, Joe, the corner pharmacy, who's seen their kids grown up. And now Joe's a PainWise pharmacist who has his logo on that, and he's going to help you with your pain. Well, that's great, Yeah.
I guess just to wrap up, I think I'd be interested. You're obviously such an inspiration to be like myself. And pain is such a niche area that not many do at the moment. I guess any advice who are interested in maybe progress more specialised?
Yeah, I do think having had the experience around, broadly, around the broad pharmacy setting, around aged care setting, I feel, and now niched very much into pain, I think I think it's got to suit your personality too, of what you can wake up to every morning and be passionate about. Sometimes, usually, and this is not just in our field, but usually even in a psychology field, people usually are drawn to what they've had personal experience about. Okay, so that's always a good point to start. If you sort of feel, gee, I wouldn't mind, being a bit excited about an area, what would it be? Start with, I think, where your experience lies, because if you can have some kind of personal experience around that, generally might be passionate about it. Okay, so I think that's a first start, where I think it's just a logical start, rather than sweat it out in an area that, I really don't like looking at gooey wounds, but everybody seems to think that, wounds is the best thing, so I better go do that, But really, it just makes me boil every time, but I'll just suck it up and do it anyway. I think that's hard to get up to every morning. So I think my advice around that is start with where you feel you can anchor to at first, and that can change over your life, which is fine, and that's okay. And then I think good mentoring is really important. Anchor on to a good mentor who will inspire, who won't be who's not jaded with the industry for a start. You don't want to entertain those voices, and there's no need to, because we as proven, you can make things up. You can make things up. You can, if there's a need, you just go and fill up the gap. It's okay. You can do that. It does take a couple of extra wrinkles and hours that you don't sleep, but it is totally possible if you don't mind giving up those things. And then be really strong in your clinicals. Be really strong with that. And I don't mean memorizing the APF. Just understand your clinicals well, and be open to draw, from good studies, or talking to other health professionals, and to even start as well being, socializing, perhaps even just at a social level. Because professionally, you ask people to go and talk to the physio, they get scared. But if they've actually already got a physio friend, they're like, oh, I'll just bring, Peter Mamain, he'll tell me about that. Start to socialize with friends or friends of friends that are sort of in that network fraternity, because you get so much just quicker to talk to them than to read a textbook. You get so much from them in terms of their lingo. And I think that gives a very broad, holistic learning perspective, for young pharmacists to know where they might want to head as well. Yeah.
Fit in into that team as well, what they have to offer.
Yeah, and identify yourself. That's right, and identify yourself as whether are you a leader or are you a team player. And sometimes that can be very personality driven. And we can't have all leaders, and we can't have all just team players. But maybe, if you are a team player and you feel that I want to be a leader, then you can work towards those things, or you try it and go, nah, that's not my personality. Then that's okay, And I think very early on, be very clear in yourself how you want your practice to be. Be very clear with what's okay for you and what's not okay for you. And I think when you have those, and they're not inflexible boundaries at all. They're not inflexible. Yes, that's right. Very subjective. But have some boundaries at least, so that you know where you will go and where you won't go. And that's, I think, because at the end of the day, you always come back to that platform. Wherever you go, from there, you'll come back to that platform as well. Yeah. So those are my sort of reflectively now, note to the younger self. I should write that, shouldn't I? Note to the younger Joyce Farmers.
Should write a letter.
Yeah, actually, dear me.
Yeah.
There's actually a song like that. But it is now in reflection, I think that's important. And I think at the end of the day too, a nice workplace is important. And I do think that if you're paving out a career, and if you're not feeling very supported within a workplace, then it may, we can't all have the most ideal workplace. I'm not saying that, because there have been many work situations I've been in where I have not enjoyed it, but I've always found a way to make things up so that I would enjoy it. You know what I mean? Like the mundaneness of,
every
and be innovative to even that very workplace, whatever that might be, because that's a very safe starting ground. And I think from now in looking back, I never knew I was an innovator. I sort of had to surrender to the fact that, okay, I think that's how your brain works.
Yeah.
It's quite a confusing journey sometimes when you get restless and make things up and they do go well and you're like, what have I become? I thought I was a farmer. Those were excellent starting grounds though. But, I think looking back now in even my very first job where I had the pharmacy assistant club in that pharmacy itself, it was just so lovely to to teach them what I knew as a young pharmacist. And it made, the pharmacy assistants bond together. And it was called, I think we called ourselves the Page Club. It was the Pharmacy Assistants Interest Group Club. So we were the Page Club.
I love it.
That was the start of my name devising. So I think, or even if it's away from the pharmacy, serve within the community to, whether it's Lifeline, because you get so many other skills from there that boosts your confidence up, so volunteering, it doesn't always have to be paid, because as a young pharmacist, you're really just trying to give yourself all the ingredients in the cupboard. You're not really making that cake yet, because one day you'll be able to whip whatever cake up you want, but you're just putting all those ingredients in the cupboard so that, on the day you want the sauce, you put the sauce in, but you've got the sauce, So it's really about that, and don't rush that process too quickly, and some of the ingredients, I don't know, if you really want it to go into academia, it may be, a postgrad in something, if that tickles your bells, Other things might be more practical. Like I said, it might be the volunteering stuff because you want to have more exposure around, mental health cases, things like that. That's another ingredient put into that cupboard. So essentially, I think as young pharmacists, that's what we're doing. We're putting ingredients in the cupboard, and then the cake will be clearer as to what that looks like, or maybe multiple cakes later on. Yeah.
Oh, good. Well, Joyce, thank you so much for joining me this morning.
That's all right.
I really appreciate you taking the time. I know you have a very busy schedule, and your journey is so emotional. I think what I've heard from you is that you've got a really selfless approach to helping other pharmacists help their patients with pain. So thank you very much.
That's right. It's a pleasure.